That this works is that we're going to talk about the postpartum mother first and the changes that occur with her. Have you gotten to feel funduses? Fundi. Has everybody gotten to feel those? Have you felt a boggy fundus? Has anybody gotten to feel one that's boggy? Somebody got to feel one that was shifted. Kayla got to feel one that was shifted because of urine, a full bladder. So that's a good thing. That means that they're contracting the way they're supposed to. But we do know that, let's talk about the uterus first. It has to go through a state of what we call involution. Involution. And what that means is that it's a return to its non-pregnant state. Because remember that the uterus is very tiny. You can't feel the uterus on a non-pregnant woman. It's down in the pelvis. You can't feel it. So it has to return back to a non-pregnant state. Immediately after birth, it rises up, and then it starts to descend. It's almost a shock response that everything's gone, and so it kind of rises up a little bit, and then it starts to descend 1 to 2 centimeters every 24 hours. 1 to 2 centimeters every 24 hours. Okay. What causes it to do that? How does it do that? What's making it do that? The contractions. The contractions. So those are extremely, extremely important to make sure that that uterus is involuting the way it's supposed to. Now there's a term called subinvolution. Subinvolution. And that means that's the failure of the uterus to return to normal. And the most common causes of subinvolution are retained fragments, retained placental fragments, and infection. So those are the two most common causes: retained placental fragments and infection. Okay? So 1 to 2 centimeters every 24 hours. By the time the woman goes for her 6-week postpartum checkup, it should be almost within the pelvis again. You may still, an examiner may still be able to feel it just slightly above the symphysis pubis, but it should go right back down into the pelvis by around that 6-week checkup. And so we would not be able to feel a fundus on any of us anymore. Okay? All right, the placental site, okay? I think one thing that makes this whole situation a miracle is that we are able to, our body regenerates itself so that we can have another baby again. The lochia that is coming out after the baby is born, which there's the 3 different types. We've talked about that: rubra, serosa, and alba. You may see it called blanca as well. It's the same thing, white. That lochia is flushing the body out just like a normal period would. And what's happening is that's the endometrial lining that was left after the baby was born. That's the endometrial lining that was left after the baby was born. The endometrial lining grows upward, and as it's growing up and regenerating itself, it causes all that tissue to slough off. And so that's what is the period that you see. That's the blood that you see. Okay. The good thing about that, as it's growing upward, as it's regenerating itself, it prevents scar formation. Because if it's scarred, then we would not be able to have another baby. But it prevents scar formation and allows for another pregnancy. So it's an upward growth of the endometrial lining. Causes all that necrotic tissue, all that old tissue to be sloughed off, just like a period. That's what you see with the lochia. That whole process should be completed by the 3rd week postpartum. So by the end of week 3, the endometrial lining should be bright, shiny new. Okay? We've talked about lochia before. You know that anything more than, you should not feel more than 1 pad an hour. And when I talk about the pad, I mean those big maternity pads. Y'all have seen those. Hopefully y'all have seen those. Those look like diapers, pretty much. They're big, huge pads. So anything that feels more than 1 pad an hour should be investigated. And clots larger than a $50 size should be investigated. That doesn't mean that it's going to end up being a bad thing. It may just be that she forms large clots, but they still should be checked and looked at really closely. Okay. That period, that lochia, may continue up until that 6-week postpartum, especially in C-section mothers. So that is going to continue up until that 6-week postpartum. When there's no more drainage, when there's no more lochia, when it's over, that means the cervix is closed again. Okay? So an end to the lochia means that the cervix is once again closed. Is it that perfect shape again? No. Remember, it's no longer that perfect little donut. It's now a squished, flat, jagged slit, like a squished donut now. Okay. All right, the vagina and the perineum. The vagina is very edematous during the postpartum period. That should go away around 3 weeks and totally return to normal, or it starts to disappear at 3 weeks, but it should totally return to normal between 6 and 8 weeks after childbirth. It takes a while for all that edema to disappear. And a lot of that's going to depend on tearing, lacerations, anything that occurred during the birth process. If you've got a vaginal tear or a vaginal laceration, if they had to do an episiotomy, that might take a longer time for that edema and that swelling to disappear. There is going to be some vaginal dryness, especially in women who are breastfeeding, and it's because of the suppression in estrogen. Okay. Especially women who are breastfeeding due to the suppression of estrogen. This rain makes me want to go to sleep, like crawl in the bed with my pajamas and go to sleep. I'm sitting here just looking at it like, okay. Episiotomies, we talked about how to check for episiotomies, check for infection. You turn them to their left side. Thank you. It may take a while for complete healing to occur. And remember, we check Rita when we're looking at episiotomies. Has anybody seen an episiotomy? Has anybody seen an episiotomy during the birth process? Were they cut? A couple of you did. Okay. And they stitch those closed, so we've got to make sure that stitching is healing. So we're looking for the redness, the erythema, edema, drainage, approximation, all those things, making sure that the ecchymosis, making sure that that's all healing properly. That it should only be seen in certain positions. You should not be able to, it should not be this gaping wound. It should only be seen in certain positions. Even in 4th degree lacks or 4th degree tears, you should only see it in certain positions. Okay, now this is a big catch, ovulation. This is how you see some of these women coming in with a baby. They're pregnant at their 6-week checkup again. They're pregnant again at their 6-week checkup. Because they didn't listen to what the doctor had said. We're not supposed to, you tell them they're not supposed to have intercourse until their 6-week checkup. A lot of women and their partners don't want to wait that long. But they run that risk. Now, ovulation, it varies, of course, between lactating and non-lactating women. But one of the things to really impress upon your patients is that breastfeeding is not a guarantee that you're not going to ovulate. Some women think that just because they're breastfeeding, they're not going to ovulate. And yes, it does suppress ovulation. But you have to breastfeed consistently all the time in order to not ovulate. Okay? A lot of women do both. Like they'll breastfeed and they'll also bottle feed. Okay? That is not going to suppress ovulation. It has to be exclusive breastfeeding in order for you not to ovulate. Ovulation in a non-lactating woman, so a woman who decided not to breastfeed, who is bottle feeding, will resume ovulation by 6 months at the latest, but it's usually around 3 months. So somewhere between 3 to 6 months, they will resume ovulation, women who are not breastfeeding. Months. So they will have a delay in return of ovulation. Nathan, months?
You said non-lactating?
Non-lactating women, women who are not breastfeeding, they still have a delay in ovulation, but it only it's usually between 3 and 6 months. Not all. I mean, there's always going to be somebody that's not the rule, right? And lactating women, their ovulation is delayed as long as they exclusively breastfeed. Okay? Even when they're nursing, they will probably resume ovulation by 6 months. Because as a baby gets older and they're introducing foods, they're not breastfeeding as often as they were. So as they get older, that's when ovulation starts to occur. So you've got to teach these patients that breastfeeding is not a form of birth control, because you'll get people in there all the time that voila, they're 6 weeks postpartum checkup, they're pregnant. And how many of you have seen them ask what form of birth control they want? You know, that's one of the questions that you ask a postpartum mother before they leave the hospital. What form of birth control are you going to have? And they will go ahead and administer or write the script for some of these things before they even leave the hospital. And that's the best thing to do. They need to allow their bodies to rest, because remember, it's going to take a while for everything to start to regenerate and to regrow and all that stuff, the edema to go away. They need to let their bodies rest. Okay. The abdomen. Striae, we talked about that. Remember the striae gravidarum, which is the stretch marks, typically will remain no matter how much cocoa butter you slathered on yourself. Okay? It will remain. For the first few days after birth, the abdomen typically still appears pregnant, even though it's softer. It's not that hard abdomen like you saw when you were pregnant. It's a little bit softer, and that will go down. And of course, we're going to talk about weight loss. You do lose more weight when you're breastfeeding quicker. There is a condition called diastasis recti abdominis, and I think I've mentioned this one other time. Diastasis recti is when the muscles of the abdomen separate out. That is not a common thing, but it's more common in women who are overweight going into pregnancy, so they already are obese, or they have they lack of exercise, they have poor muscle tone. any of those conditions can result in diastasis recti. They don't do surgery to repair that. You can have plastic surgery, but it's not something that's an elective surgery. It's not something that has to have surgery done to survive. It does become less apparent with time, and a lot of these women end up wearing corsets or something like that to kind of try to keep the muscles together. It doesn't hurt. It's just unpleasant looking. So this is a picture of the muscles that separated out. Okay. All right, the breasts. In breastfeeding mothers, they may feel a lump or a mass that shifts from day to day. That's the milk starting to come down. Colostrum begins right after birth. That's the yellowy, thick milk. You run into a big problem with Hispanic women because they don't want to feed the colostrum. Have you heard that yet? They typically don't, and you have to explain to them that that is actually the best milk that they can get because it's full of immunoglobulins, and it's going to be the best thing for the baby at that point. True milk, what we consider true milk, starts somewhere between 2 and 3 days after birth. When you let down, when the milk lets down, you will know. That's what I always tell those breastfeeding mothers. You can't miss it. It feels like you go from nothing to this heavy, warm feeling in your breasts. So there is some warmth. In non-breastfeeding mothers, colostrum is still present. The catch is that it should not, if they have decided that they're not going to breastfeed, you should not start expressing it. Because if you start expressing it, even with the colostrum, that milk's going to let down, and you're going to be in the same situation as a breastfeeding mother. Okay, so they've got to be really, really careful never to allow it to be expressed. Now, used to years and years ago, they would give a medication that, like paregoric or something like that, that would dry up the milk. They don't do that anymore. There's nothing that dries up the milk. They have to kind of suffer through it until it's gone. A lot of those women will wear breast binders to keep their breasts tight and not, sensitive, not rubbing up against anything, to help for that milk to dry up faster. But it is uncomfortable as it is drying up with that heavy feeling.
I had a lady use cabbage leaves in her bra.
Yes. We use cabbage leaves for engorgement a lot, and even in breastfeeding mothers. Cabbage leaves are wonderful, and every unit that you ever go on, every L&D unit that you go on will have a head of 2 of cabbage in their freezer. Frozen leaves, there's something in cabbage that pulls the tenderness and warmth out. And you tell them that when the cabbage leaves wilt, that's when they toss them, and they put another one in. Yeah. Okay. What are you looking for when you're inspecting the breast? We talked about this under postpartum assessment. Cracking, blisters, bleeding. If they're bleeding, reddened areas, all of those things might be a sign that mastitis is beginning, and you definitely don't want them to get mastitis. Mastitis is miserable, miserable, miserable. Be really careful. Most of the time in a breastfeeding mother, if you see cracking, that means that the baby is not latching properly. We're going to talk about breastfeeding and how to properly teach someone to latch later on, but you've got to be really, really careful about that. That's typically what that means. Breastfeeding should not hurt. It's going to be uncomfortable, especially for new mothers there in the beginning, because they've never had that situation before. But it should not hurt. If you've got a new mother who is crying in pain, there's something wrong. And typically what it is that the baby's just not latching properly. And so they just have to be taught how to do that. Okay? All right, the GI system. A lot of women who have had tearing or episiotomies or lacerations are scared to have a bowel movement the first time because they're afraid it's going to hurt. And yeah, it can hurt. I told you about the lady that was in our PN program a couple of years ago that told me she had a 4th degree tear. She went and had a bowel movement for the first time and totally ripped open again. It is definitely a concern for those women who have had surgery down there. So that's why we give them stool softeners. That's one thing that is given to these women postpartum is stool softeners. And of course, encouraging them to drink lots and lots of water so that they don't get constipated. Pain medications are going to constipate. So any narcotics that they're having to take will constipate them. So you've got to teach them all of the things that you would teach somebody to prevent constipation. Fiber and water and the whole things. Okay. If you've got someone who has had an episiotomy or a laceration or a tear, something like that, teaching them to do pelvic exercises. We talked about Kegels the other day. Teaching them how to try to tighten and relax and all those kind of fun things will help them prevent any incontinent episodes. Because if you've got somebody who has a 3rd or 4th degree laceration or tear, they may have some incontinent episodes. Because remember, those 3rd and 4th degrees have gone all the way through the anal sphincter and the wall muscles. So you've got to be very, very careful with those women, teaching them how to strengthen those muscles are very important. All right, the kidneys return to normal within about a month after birth. So they may still have a risk of getting a urinary tract infection because of the dilated ureters that occurred during pregnancy. Those dilated ureters are going to remain dilated for about 3 months. So that's going to prevent adequate emptying. So they may have urinary tract infections, higher risk for urinary tract infections. Because there's also going to be a decreased urge to void because of the dilated ureters. So even at home, when they go home with the baby, they need to be taught how to go to the bathroom frequently, like they do on the unit. Every 2 hours, they need to be getting up and trying to go to the bathroom. Remember, too, that not only are we trying to prevent a urinary tract infection, but we're trying to prevent that fundus from not contracting, because a full bladder is going to cause the contractions to subside and that fundus to become boggy. So we're trying to prevent that from happening as well. One of the biggest complaints is postpartum diuresis, especially at night. Women are going to the bathroom all the time. What causes that is a decreased estrogen level. Remember, all those hormones are really erratic in those first couple of days postpartum. So when the estrogen drops out the bottom, it's going to cause them to have to go to the bathroom more. There's also going to be a change in the venous pressure because all that circulation has gone now. So the body is trying to get rid of all that fluid on its own. And the way to do that, the way to get rid of all that excess fluid, the edema in the legs that was there at the end where they had a lot of edema in the legs, all that fluid has to go somewhere. And so the body is going to try to get rid of it through urination. Okay? All right. Blood volume decreases blood volume decreases, we don't need to supply extra blood volume to this alien that has taken over our baby, our body. And it returns to a pre-pregnancy level by around 6 months postpartum. Okay? And that decrease in blood volume is okay. Normally in a non-pregnant person, we would worry about a decreased blood volume, wouldn't we? That would be a sign of dehydration, something's wrong, decreased circulating volume. But here it's okay because that uteroplacental circulation is now gone. We don't have to supply it anymore.
Is it 6 months?
6 months. Okay. Initially, cardiac output remains high because when the baby and the placenta is born and then the cord is cut, there's such a rapid change in hemodynamics, there's such a rapid change that cardiac output can't keep up. So it remains high initially and then it starts to drop. Now cardiac output returns to a pre-pregnancy level by around 12 weeks. So remember, in a pregnant woman, you may hear a murmur. Remember we talked about that? You may hear a murmur because there's an increase in cardiac output, an increase in blood volume. Now those things are dropping rapidly. So that murmur should go away. If it doesn't go away, then we're concerned about a postpartum cardiomyopathy. Blood pressure and pulse should remain stable, but when all that's occurring, when they're rapidly changing fluid status, they're rapidly dropping, that blood volume is starting to decrease, the cardiac output is up and down, up and down, up and down, you may have some orthostatic problems. So it's not uncommon for a postpartum woman to get up, stand up to go to the bathroom and feel dizzy or faint. And a lot of that, again, is because of that change, that rapid change in the cardiac output, the fluid status. All right, other things that we need to worry about, other concerns. The first one is some specific lab values I'm going to talk about. The first one is WBCs. Your white blood cell count is going to remain elevated for about a week. And a lot of people confuse an elevated white count in a postpartum woman as a sign of infection, and it's not. So you can't rely on that to tell you that the woman has an infection. Your best indicator of an infection in a postpartum woman is a fever. So you're checking their temperature. That's what you're going to go on, not the white blood cell count. Okay, and we're going to talk about the same thing with babies in just a little, well, maybe not today, but tomorrow. Okay, so white blood cell counts are not an indication of an infection. A fever is a better indicator. Okay. You're going to have a decrease in their hemoglobin and hematocrit, and it's not necessarily due to the amount of blood that they lost in delivery or in a C-section. More than likely it's due to the diuresis. Diuresis causes hemodilution, and so that's going to cause a decrease in your hemoglobin and hematocrit levels. Platelets also are affected. You will not see a normal platelet count until about 6 weeks postpartum. Okay. So those are the three big ones that we're looking at: WBCs, H&H, and your platelet count. Weight loss, there's initially about 10 to 12 pounds of weight loss with the birth of the infant, the placenta, and the amount of fluid. So initially you lose about 10 to 12 pounds right off the bat. With all of that diuresis taking effect, that you're going to lose another 5 or 6 pounds. And then the rest of the weight loss is going to be determined by either if you're breastfeeding, you're going to lose weight a lot faster. If you're not breastfeeding, it's up to you to help you lose that weight faster. Okay, so 10 to 12 with the baby, the placenta, and the fluid, and then 5 to 6 with the diuresis that's occurring. And again, those numbers are going to vary, so don't hang on to those for dear life, but that's an approximate amount. It's going to vary person to person. Okay. Right after birth, and I don't know if you've noticed this or not, but right after birth, women have intense shivering. Have y'all seen that? They say they're just, and I remember that after my C-section, after that, as they were reversing my spinal block. As they were reversing that, I remember those chills, and it's to the point where you can't control it. I mean, you're just shaking, and your teeth are chattering, and you're just shaking, but there's nothing you can do about it. And you're not really cold. What it is a change in the hormone levels. Your hormone level change causes that intense shivering. An adrenaline rush. If they've vaginally delivered and there's this big adrenaline rush, that will cause an intense shivering. So if there's no fever associated with it, then, bless you, then you just, reassure them that it's going to go away. It's not a concern at that point. So you can give them a warm blanket. That may help. Again, it's not that they're necessarily cold, but it may comfort them. At night, they're going to have a lot of sweating, a lot of diaphoresis. And again, that's because of that fluid loss that's occurring, all of that fluid loss. So, not only are they getting up to go to the bathroom all night, but they're also sweating, and that gets rid of some of that fluid. Okay. There is a condition called after pains. It's not really a condition, it's just something that occurs. After pains are more common in women who have had a baby already, what we call a multipara, women who have already had a baby. And after pain is just pains with contractions. They tend to be more intense in women who have already had one baby. There's not a whole lot you can do about it besides taking some ibuprofen just to control it. And of course, they're going to become worse. Those after pains are going to become a little bit worse if you're breastfeeding. When you start to breastfeed, it does cause the contractions to become more intense. So those after pains are thus more intense. So taking ibuprofen, and I always just tell the mother, just take it before you start to breastfeed, about 30 minutes. If you're on a schedule, go ahead and take it, and then that'll help with some of the pain. It'll help take it off. Okay, let's talk about attachments. They call that period taking in and taking hold. Taking in and taking hold. Remember we talked about in the pregnant woman that they had to go through those phases, the I'm pregnant, I'm going to have a baby, I'm going to be a mother. Remember those phases? This is similar to that phase where we talk about the taking in period is you're taking in the fact that you are now a mother. Those women typically are very hesitant. They are more reliant on someone else to make a decision. It's a big change. Okay, so you're taking in becoming a mother. It can apply to the fathers as well. You're taking in being a father. They're very nervous, especially first-time parents are very, very nervous in that initial 24 to 48 hours. They're very hesitant and reliant on other people to tell them what to do. The taking hold period The taking hold period means that you're ready to take control of the baby yourself. You're able to take care of it now, without relying on someone else to help you make that decision. So taking in and taking hold. Okay. Now, one thing that may delay the taking in and taking hold period are women who've had a C-section, because they don't initially get to see that baby. So that whole taking in period is kind of delayed. They have to go to a recovery room to recover from the surgery before they get to see or hold or touch that baby. Now, those of you, has everybody been in SIM yet? Or do I still have some that are coming this? Okay. All right. Well, let's talk about, we're going to go ahead and still talk about it. What I asked everybody to do in their first day of SIM is to look at your culture of your patient, to look it up, and to see how they handled pregnancy, labor, and delivery. Remember I talked about that, and postpartum. So what I want us to do now is let's talk about that. Let's talk about the different cultures. And even those of you who hadn't been in SIM this week, you'll still do it, but you'll just kind of get an idea of some of your the cultures that you'll see. Now, culture can affect the taking in and the taking hold period, because some of these cultures rely on other people to take care of the baby while the mother is recovering. Okay, so what about, let's think about the cultures. We had the Muslim culture. Okay, so those of you who had Cassandra, what did you discover about that culture? Nothing.
They remain covered during the birth.
Okay, they remain covered during the birth.
They look at it as an honor and a privilege, like for them to be able to give birth.
Okay.
So they get rewarded afterwards.
They get rewarded for giving birth.
And more if it's more.
More if it's a boy, right? They want a boy. Girls are not as valuable as boys are. Okay?
They didn't like men in the room.
They don't like men in the room. So if the male is not present, and there's other cultures, who had another culture where the man wasn't necessarily supposed to be in the room? The Haitian, right? Haitian Americans, okay? They don't want the men in the room. So if we're talking about taking in and taking hold, is that going to delay that with the father?
Mm-hmm.
Yes. Okay. What else did we learn about your culture? We had Vietnamese, we had Haitian, we had...
The Indonesian, they didn't believe in prenatal care.
Okay.
But then they did believe that the doctor was like all knowledgeable, so whatever he say they would do when they did go into the hospital.
Okay, so they didn't make a decision on their own. They don't get prenatal care.
But when
Whatever he says, that's what they're going to do.
Not question.
Okay. All right. What else did y'all learn? I know y'all had to come up with some more stuff than this. They have some really odd things in some of these cultures.
They also, the Indonesians sometimes bury the placenta under where the bed is, like under the floor.
Okay. Under where the birth occurred, bury the placenta.
I know that there's a culture where the mother doesn't take care of the baby, the grandmother does, but I don't know what culture that is.
Yes. And that's common in like the Japanese culture, especially. They don't take care of the baby. And some of these cultures, and I believe Haitians do this too, they're secluded
For a month.
for a month afterwards. Mm-hmm. They don't go out of the house. They're in the house with only female people coming in and out for a month.
Then they have to take when they take their baths, I think the first bath has to be in cold water. The second,
Right.
Yes, for 3
Yeah.
months.
The 3 baths are
baths.
specific. They have to take different types of baths. Okay. All right. Anything else?
I was reading in the book that there's one where the father like whispers a blessing in the baby's ear and
Yes.
washes the baby off
Yes.
if there's a complication.
Now I know Muslim culture they do that. They whisper prayers in the baby's ear to Allah. Okay.
There was one where we read somewhere about they don't want any praise about the baby because of jealousy, or they think that they don't want you to say anything like good about it because they don't want the baby or be jealous.
Right, yeah. And some cultures are also very, the Asian cultures, a lot of the Asian cultures don't want you touching the top of the baby's head. And what do we do when we go into a baby, when we see a baby? You want to rub that sweet little soft downy head, right? And they feel like if you touch their head that you're giving them evil spirits. That's a very, very bad thing to do. So you see why some of this stuff is important for us to know? If you go into a room and you start stroking this baby's head, I mean, you have definitely caused some trouble. Okay? So do you see how some of these cultures you can have a delay in some of this, and some of this taking in and taking hold, period? Anybody else remember anything exciting, interesting?
I think with the Haitians, it was the father made the decisions as far like, but if it was a single mom, they went to the elder in the household.
Yes, yeah, the elder or the father, the male makes the decisions for them. Yes. Okay.
I don't know what culture is, but I've heard, don't some people eat the placenta? And
Yes.
I've heard of people like burying it with a tree or something.
Yes. A lot of the Indian cultures will do that. Yeah. So a lot of things for you to think about when you're dealing with other people. I had a student a couple of years ago who was from, gosh, where was she from? An island. It was an island country. She got, she told a story, and it was, when she told it, it was just kind of like, just in the class, it was just kind of matter of fact, and I didn't really know even what to say to her after, and I don't think anybody else did either. We were just kind of stunned that she told it. She said that she got pregnant when she was young, and that was a very bad thing for her to get pregnant. So she decided that she was going to go down the street to the local whoever, witch doctor, it was some local healer who was going to give her something to miscarry this baby. So she took it. She said it was some kind of liquid that she drank, and she took it. I think she was 13 or 14. And she went back home, went back up the street, went home, and she actually miscarried at home in the toilet. And she was bleeding out quite a bit. She was having a lot of trouble, and so it's a miracle that she's even. Hello, we're talking about different cultures. Okay, anybody else have any other stories? Anything you've heard? Okay, all right. All right. So, how do we care for these mothers during the 4th stage of labor? And remember, the 4th stage of labor is after the birth of the placenta, when homeostasis is reestablishing itself. So they're going to have a lot of perineal discomfort. Ice packs help. I know that a lot of the hospitals now are using baby diapers and putting water on them and freezing them. I think that's the greatest thing in the world. They're tossable. You know, they're great. So ice packs will reduce the edema that's occurred. We just talked about vaginal edema. Sitz baths. Has anybody seen a sitz bath? And we don't really do the baths anymore. We used to have the little tubs, the little pans that you use. We don't really do those anymore. Mostly it's just peri bottles that they use. They'll fill it up with nice warm water and they squirt it on their perineal area. It helps to decrease pain. It also promotes circulation if you've got warm water. You have to be very, very careful with these women not to get into really hot water or really hot showers, because remember, everything is changing and dropping, and they will faint in a heartbeat. So you've got to be really, really careful to make sure that it's not too hot, that the water's not too hot. There's a lot of other things over the counter now. Dermaplast spray, Tux, which is witch hazel. Have y'all seen those little pads, the Tux pads? Those help with hemorrhoids or tearing or lacerations. So a lot of different things. Does anybody see anything different? Anything new out there currently? Those are pretty much the same things that we've always used. The perineal bottles are really, really good, especially if they've had a tear or a laceration or a episiotomy, because it helps to keep that area clean. Because remember, we're trying to prevent infection in the episiotomy or the incision. All right, suppression of lactation. If you've got a mother who doesn't want to lactate or breastfeed, then they need to make sure they wear a tight-fitting bra. They can use ice packs to help with engorgement or the cabbage leaves. Vaccination. Remember, if they're rubella negative, they're going to get a shot, an MMR, before they leave the hospital. The biggest thing to remember about rubella, about the MMR vaccine, is that they cannot get pregnant for 3 months. Cannot get pregnant for 3 months because it is a live vaccine. It will cause lots and lots of problems in a baby, in a fetus. Another vaccine that you might see given is Rogam. Has anybody seen Rogam given? Yes, a couple of you. And then now I believe they're giving tetanus to women who haven't had a tetanus shot lately. Tdap. Okay. And we'll talk about postpartum exercises in just a little bit. Okay. All right. You want to take a little 5-minute break? We won't take a long break. Types of hemorrhage in postpartum period that you're really concerned about. Early postpartum hemorrhage is during the first 24 hours after birth. The most common causes of early postpartum hemorrhage are failure of the uterus to return to normal, or that uterine atony, what we call atony, A-T-O-N-Y. Lacerations. Or, and this is, we're going to talk about this in just a second, uterine inversion, where the uterus turns inside out, like a sock. Uterine inversion. This is early postpartum hemorrhage. Okay. Uterine atony, lacerations, or uterine inversion. Late postpartum hemorrhage is typically more than 24 hours after birth, but less than 6 weeks postpartum. So somewhere between 24 hours of birth, but less than 6 weeks postpartum. That's what we call late postpartum hemorrhage. Okay. Late postpartum hemorrhage is usually due to what we call that subinvolution. Remember we talked about that a minute ago? Subinvolution of the uterus. It can also be caused by placental fragments and endometritis. Okay. Now, they consider it to be a hemorrhage if they've lost 500 milliliters or more during a vaginal birth, 500 milliliters or more during a vaginal birth, or 1,000 cc's or more after a C-section. The problem is that at delivery time, it's really hard to tell that they've lost 500 milliliters or more. It's very difficult to tell that because of everything else that's going on, okay? So you have to be really, really careful to really assess the other signs and symptoms, okay? So vital sign changes, level of consciousness changes, all those things that you would normally see on someone who's hemorrhaging or something that you want to look for. Okay? All right. So let's talk about early hemorrhage. We talked about those three things. Uterine atony, of course, is 90% of all cases of postpartum hemorrhage. 90% of all cases of postpartum hemorrhage is due to uterine atony or a boggy uterus. Okay, a boggy uterus. Okay, it's not contracting the way it should. Okay, now there are some causes of uterine atony, people that are more at risk for it. Women who had hydramnios are more at risk for having a boggy uterus. Women who've had a large baby, what we call macrosomic babies. They're really, really big, large babies. Bless you. And multiple fetuses, so your twins, your triplets, your quads, because that uterus is overstretched. All of those causes, the hydramnios, a really large child like the 12-pounder that Amanda was talking about, or the multiples can cause that uterus to be stretched out too much. And so it has a harder time returning to a normal state. So it takes longer for those contractions to really cause it to firm up. So it's just kind of flaccid and boggy. Okay? All right, lacerations. The problem with lacerations is that they may be a slow trickle. You may not notice them at first because it's a small laceration. That if it continues to trickle, and it's like kind of like a water faucet. You don't realize how much water you're losing until you get the bill for that slow trickle. That's the same deal with a early hemorrhage with a laceration. It may be a slight trickle or an oozing. And it may not just be the laceration, it may be from the episiotomy site. So you really have to be very careful to look to where it's coming from. Uterine inversion. There are two types. There's a complete inversion, which is an obvious inversion. You open their legs and there's this big, large, red, round mass protruding outside of the vagina. It's this big red ball outside of the vagina. And you're not going to even have to look for it. They're going to know because there's this big red mass between their legs. Okay? An incomplete inversion can't be seen, but it can be felt by a practitioner. When they go in to do a check, they can feel that it's inverted. The most common cause of it is excessive traction on the umbilical cord, pulling it out. Excessive traction can cause a uterine inversion. It's not ready to come out. If you've got a placenta that's still stuck, that's still attached by some of those villi to the sidewall, they haven't broken off yet, and you're sitting there pulling on it, all it's going to do is turn it inside out, and it turns it inside out like a sock. Okay. Vigorous fundal pressure. If you massage that fundus too much or too hard, it can cause it to invert. Okay. Now, signs and symptoms are going to include hemorrhage, shock. They're going to go into shock. And pain. They're going to be in excessive pain, which you can imagine if your uterus is turned inside out. And they will have to go in and do a hysterectomy for that. There's not much else you can do. Unfortunately. Okay. All right, late hemorrhages. subinvolution. The contractions are not causing the fundus of the uterus or the uterus to return to a normal size. It's just taking longer for some reason. One of the most common causes of subinvolution is infection. If there's a lot of infection up in the uterus or in the endometrial lining, it cannot return to normal. It can't involute. It can't drop those 1 to 2 centimeters like it's supposed to. Signs and symptoms of the infection, and you've got like your endometritis. We're going to talk more about endometritis later, but they complain of feeling like they have the flu. There's a foul smell to the lochia, kind of a fishy smell. They typically are running a fever and they have backache, so they're pretty sick. And then another cause of late hemorrhage is placental fragments. And of course they should find that. You know, once the placenta is delivered, they inspect it, and they're supposed to be able to find all those fragments that are missing and go in and retrieve them. It should not take this long for them to have discovered this, but sometimes it can occur. An ultrasound can show any fragments that can't be felt. And then if they can't retrieve them manually, they'll have to go in and do a DNC. And that's typically the only course of treatment for retrieving fragments that can't be retrieved manually. Okay. All right. Somebody Candy, you want to run in and get Miss Norris? Okay, so we were talking about early and late postpartum hemorrhage. Let's refresh our memories. What causes early postpartum hemorrhage? There are 3 things: acne, uterine acne, lacerations, and inversion. Inversion. Remember, uterine inversion. And we have 2 different types of uterine inversion, right? Complete and incomplete. What is a complete inversion?
Very obvious.
It's very obvious. You can see it. It's this bright red shiny ball protruding outside of the vagina. Thank you, Nathan. Okay. Now, I want to tell you something about that too. About inversions. That is a little bit different than a prolapsed uterus. Okay? A prolapsed uterus or a prolapsed bladder occurs typically in older women who have had multiple deliveries because they lose the strength in their muscle control. They lose all that strength and it starts to prolapse. So it is a little bit different. Don't confuse an inversion with a prolapse. A prolapse just occurs because of age and weak pelvic muscles. Okay? And, you know, prolapses, that's when you see these little old women come in the hospital and they've been sticking their finger up and poking it back in for Lord knows how long, you know, to be able to go to the bathroom and all this stuff. And, but an inversion is something totally different. An inversion occurs, remember, it's like a sock that has turned inside out. So it's like when you do that's the best way I can use to describe it, because you're turning it inside out, or a pillowcase. Okay? All right, what causes a late hemorrhage? The subinvolution. It's a failure for it to be descending in the pelvis. Fragments. And infection, endometriitis. And typically subinvolution is because of an infection. That's what you see. Okay? Alright, so when did we see early hemorrhage? When would you see that?
Less than 24.
Less than 24 hours. And then a late hemorrhage is Greater than 24 hours, right? Up to 6 weeks. Up to 6 weeks. And that's the scary part, because it could be that they're coming in for their 6-week checkup and just now finding this out. We know it can be an infection or endometriosis because what? Smell. We smell that fishy smell, a fever. They feel like they've got the flu, pain. They just feel horrible. Okay, if you've been in Sim with me, those of you who had Jeanette, was it Jeanette? She had that card that said she just didn't think it would feel this bad, labor would feel this bad. Okay. Remember, endometriosis can occur too because of surgery. Remember, C-section can cause an inflammation, or an infection. So endometriosis can come from a C-section. So if you've got a patient who's had a section, that can also cause endometriosis. So you have to be really careful with that. Okay. So how do we manage these people? If you've got a hemorrhage, the first thing you're going to do is check the fundus, and you're going to see whether or not it's boggy or if it's contracted. Now, you may have a contracted fundus, and if you've got a cervical tear or laceration, it's not going to have anything to do with the fundus. So you've got this huge hemorrhage, you've got this pad that's just extremely bloody, lots of blood, and you go in expecting this fundus to be boggy, and it's not. It's contracted. And then you start thinking, okay, there's other reasons. So some lacerations, some tears, something like that could cause it. So the first thing you're going to do is fundal massage if it is a boggy fundus. There are some medications that we can give to help it to contract and to slow the bleeding down. Oxytocin is one. Methergin is one. And Hemabate. You don't see Hemabate given as much anymore. Methergin is the most common drug used. What are signs and symptoms of shock? And I know we've talked about this before. Okay, a low blood pressure, but a high pulse. Cool extremities. Clammy and pale. Lethargic. What about their urine output? Scant, decreased urine output. Remember, that is a big clue that something's getting ready to happen. I think, and I've said this before, I know I said it during fluid and electrolyte balance, but I really want you to tuck this in the back of your mind, because I think we miss this a lot. We go in our rooms to check on our patients, and we just barely glance at the Foley. We don't really pay much attention. I mean, I know you all have done that before, because I've done it before. You go in, you just kind of eyeball it and move on. You don't pay attention to the fact that all of a sudden they're not outputting anything, and that's a looming sign. We're getting, because the body is trying to do what? It's trying to shift what it does have to the vital organs, right? So the brain, the heart, the lungs, and the things that are not necessary, like kidney function, they stop. So really pay attention to their urine output. It can give you a clue to a lot of different things. Okay. Maintaining IV access. If it's a laceration, of course, it's going to be sutured. If it's a bleeding vessel, it could just be something that there was a nick and there's a bleeding vessel that just keeps dripping. They can go in and they can ligate it, or use some, oh gosh, what's that stuff called?
Silver nitrate?
Yeah, silver nitrate to ligate it. Kind of burn it off. So it depends on the cause. To the point where they may have to go in and do a DNC. If it's placental fragments, like we talked about yesterday, they may actually have to go in and do a DNC and clean it out. The problem with that is that it will cause more scarring to build up. So remember that one of the causes of preterm labor is excessive scarring, or excessive DNCs, excessive cartridges. Okay. So you got to be really careful with that. All right, let's talk about other things that can happen. Postpartum infection. Now, there's a fancy word that your book uses called puerperal, and all that means is postpartum infection. That's all that means. And there can be a lot of different type of infections. The most common type of postpartum infection is endometriitis, or any of those that are under the umbrella. Remember, PID is the umbrella, and underneath that umbrella are all the itises, the endometriitis, the parametritis. Remember all those that are under the umbrella? So that pelvic inflammatory disease is the most common postpartum infection. Typically, it begins at the placental site, and then it moves to the endometrium, especially the cervix. Okay. They will do a culture to tell what organism it is, and that's how they're going to treat it. Blood cultures, they may do a tissue culture, a fluid culture, some kind of culture to tell what the organism is so that they'll know how to best treat it. These women are sick. And again, remember, they feel like they have a fever. I mean, they feel like they have the flu, they have a high fever, and you see the other signs and symptoms of their chills. They don't want to eat. There's that foul-smelling lochia again. These women want to stay in the fetal position. It hurts to stretch out. It hurts to move because all that inflammation in the pelvis is so painful. So it feels better when they are kind of in that fetal position with the knees drawn up. These women are going to have to be hospitalized in order to treat this. This is not something they can treat at home. These women will be in the hospital. The most common types of organisms that cause this are strep and staph. Streptococcal organisms and the staph organisms. Okay? So, again, C-section puts you at risk for this. Premature rupture of membranes can put you at risk for this. Because what's happened? What happens when you have a premature rupture of membranes? You're sitting free, wide open for everything to just crawl up in there and plant itself. Okay? Now, if you've still got the baby, if you're still pregnant, if you hadn't had the baby yet, you've had the premature rupture of membranes, and all these nice little buggies crawl up in there and implant themselves in the placental site, what does that put at risk for the baby? Infection in the baby. The baby can get an infection too. So after they're born, we may start seeing signs and symptoms of infection in the baby. And those of you who've had me in SIM already know that we've seen that. It can put the baby at risk as well. So it depends on when they got infected. That's the biggest thing. All right, wound infections. The most common types are perineal from your episiotomy or laceration sites, not keeping them clean, and C-section scars. And I'll tell you a story. I got an infection in my C-section scar. I don't think I've told y'all the story, have I? And she sent me home, and they had been, it was that at that time, being 9, so about 9 years ago or so, we were having a lot of infections, wound infections in the delivery rooms at Rowan. And so they couldn't figure out why. Come to find out, you know where they were getting the organisms? From the heating vents that was falling down from the ceiling during the surgery. So anyway, so I got an infection in my C-section scar, and I called her 50,000 times and said, it's red, it's hard, I'm in pain, I know it's infected. No, it's not, because you're not running a fever. And we went back and forth, back and forth, back and forth. So finally, I went in, after about a week and a half, I went in, and she said, well, it looks like it's infected. And so she said, she took a Q-tip, and remember that now the tissue had already granulated. It was already, the scar was already, it was healing, closed. And she said, this won't hurt. And she took that Q-tip and she poked right through that closed stitched skin. Thought I was going to come off the table, and all that nice stuff came out. And then she wanted to put me in the hospital, and I said no. You know how when you're a new mother, you just think you don't want to go anywhere, you're out of your mind. And I said no, I'll do it myself at home. So I had to pack my own wound twice a day for 6 weeks at home. I would lay in the bed with the mirror between my knees so I could see it. And I pull the old packing out, and wet it down, put the new packing in. It was great. So anyway, but the moral of this story is that not everyone who has a C-section or wound infection will show all of these symptoms, because I never did run a fever. I just didn't ever run a fever. So you listen to your patients. If something is wrong, listen to what they're saying to you. They know that something isn't right. So redness, erythema, hardness, so a hardened area where that C-section scar was. Remember Rita, good old Rita. She's very important, right? So we look for Rita, R-E-E-D-A, and that tells us what that incision is looking like. Typically, these are the same way that happened to me. Those wounds are left open to drain and heal by secondary intention. Because if you clean them out and then stitch them back up, you're still running the risk of getting infected again. So that's what they will do. They'll do wet to dry packing. Okay. Very, very important to make sure. Now, episiotomies and lacerations are harder to heal because of where they are. You have to be very, very careful to keep those areas clean. So what do they use at the hospital to keep them clean? The peri bottles, the peri wash. And then you teach, it's a lot of teaching about women how to keep that area clean. You'd be surprised, well, you may not be, how many women still do not realize that they're supposed to wipe front to back instead of back to front. And then they get E. coli in those wounds. And I can't imagine anything worse at that point. So a lot of teaching, and you know, even if you've got a mother who this is not her first baby, it is okay to reinforce, because you forget if it's been a couple of years. You forget those things. You know, reinforce them. Just remember, you know, you're supposed to keep this clean. This is how you do it. Don't assume that they remember. Okay? All right, so we talked about packing, antibiotics. They will put them on, especially for the PID, they're going to put them on the high-powered antibiotics. Ampicillin, vancomycin, clindamycin. Okay. Pelvic rest is very important. No tampons, no douching, and no sex. There shouldn't be anyway. But especially that soon out, whenever everything's still healing up, definitely pelvic rest. Okay. Diet high in protein, because what is the protein going to help do? It's going to help it heal the tissue, right? Now remember, let me tell you something else. Just like the fever, you cannot diagnose an infection in a woman by her white blood cell count. Remember, we talked about that. It's so up and down. It's not normalized yet. So a high white blood cell count is not necessarily indicative of an infection, or a low white blood cell count. What are you looking for? The fever. The fever. Okay? So be really careful by just looking at labs and saying, oh, you've got an infection. You've got to look at those other signs and symptoms. And if they're not running a fever, still look at the other signs and symptoms. What is that? What does that incision look like? What does that episiotomy look like? Is it red? Is it hard? Is it warm to the touch? Y'all know what it looks like when something's infected. I mean, anybody off the street should know that. If you touch it and it's hot to the touch, well, that's a sign, right? All right. Other infections that can happen during postpartum period. We've already mentioned this, urinary tract infections, because why? The ureters they're still dilated, aren't they? They have not gone back to normal. Kidney function is still sluggish, or yeah, it's elevated. Cause of pregnancy. Another factor to throw in there is if they've had an epidural or a spinal block, they don't feel the urge. There's a delay in urge to go back to the bathroom. So they may not have proper emptying because of that. The most common cause of cystitis or a bladder infection is E. coli. Again, it's that wiping. They've got to be taught how to properly wipe, how to properly clean that area. And you see I've got fever with a question mark. They may or may not. Okay, so it just depends on the person, depends on the woman, but you've got to look at all the other factors. It's like putting the puzzle pieces together. What are the other things that you're looking at? The overdistension, that inability to void. Okay. Frequent voiding is the most common way to manage it. Every 2 hours, and when you send them home, you send them home with those instructions as well. Because even though when they go home, we're sending them out fairly quickly now. I don't know if y'all have noticed that. These women are going home pretty quickly. And so we need to make sure that they understand that frequent voiding continues even when they're at home. Even though the epidural sensation has returned to the legs, they still may not realize that they have a little lack of a sensation in their bladder. So they need to make sure that they're voiding. Ice packs will help with edema if they're having trouble emptying. Ice packs. Okay. Antibiotics. The most common antibiotic for this is the sulfa drugs like Bactrim or Septra. If you're somebody like me who can't take sulfa drugs, I'm allergic to those, then they're going to use something like ampicillin. An antispasmodic that is used for urinary tract infections. Do you know which one that is? Starts with a P. Pyridium. Pyridium. What is different about pyridium? What should you let your patient know before you send them home? It turns the urine orange. Exactly. If you don't teach them that, they may panic the first time they see that urine. But it's an antispasmodic. So pyridium. Increasing fluids, making sure that they're drinking enough water, not soft drinks. Okay. They should drink some juices because like cranberry juice, apple juice, prune juice, all those will increase the acidity of the urine. If you increase the acidity of the urine, then you're less likely to have bacteria starting to build up. Okay, so no soft drinks, but drinking water or acidic juices. Cotton crotch underwear. Why? It's breathable. It's breathable, exactly. All these fancy schmancy panties from Victoria's Secret are really not what you want after you've had a baby. And I wouldn't recommend a thong for anything. Especially if you've had a laceration or an episiotomy. In that case, I definitely would not want a thong.
You get the process pain.
Thank you for that, Jason.
Breathe more, wouldn't it, Jason?
That would definitely breathe more. Sure would. Hard time holding your pad, though. Wow. Okay, moving on. Mastitis. We've mentioned mastitis already before. It is a breast infection that is caused by edema that leads to obstruction of the milk ducts. The infection causes an inflammatory edema that then obstructs the milk ducts. So it's trapping that nice sugary milk in the milk ducts. And what does bacteria love? Loves anything sweet. Sure does. And so it's going to just go to town. It crawls in, the little buggies crawl in through cuts or cracks in the nipples. That's where it enters. And they crawl up. Isn't that a great picture? They crawl up into the duct and they just go to town on all that sugary milk. And so it makes it worse and it gets infected. And then if you've ever had mastitis, you know that it is the most miserable thing on the planet. Okay? You're sick. The picture of mastitis is very similar to endometriitis, where you've got the flu-like symptoms, you've got the chills, you've got the fever, but in this case, the pain is localized to that breast. It's usually unilateral. It's almost always unilateral. So it's not something that you see on both sides. You're going to see a reddened area, some swelling. You may feel a lymph node enlargement under the armpit. Okay. If treatment is not prompt, then an abscess will set in. And then you got a whole other issue. Because if you get an abscess, then they're going to have to go in and drain that. Okay. You've got to teach these women who are breastfeeding to really pay attention to those nipples. And when we talk about breastfeeding in a little while, one of the biggest things is proper latch on. Proper latch on. They've got to get that whole areola in their mouth. They can't just munch on the nipple, because if they do that, it's going to cause cracking. It will. And remember what I said yesterday, breastfeeding should not be painful. It will be uncomfortable at first because they're not used to it. That pain, sharp, acute pain, is not a sign of breastfeeding. Okay? So they've got to get proper latch on. If they don't latch on properly, that's when the cracking occurs. That's when the lacerations occur. Now, the problem with women who get mastitis is one of the treatments is to make sure you're emptying that breast. And that's the last thing they want to do, is to pump that breast, because it hurts. And so adding the suction on top of that is even worse. But if they don't get that milk out, all it's doing is continuing to build up, right? And it's giving more food to that bacteria. So frequent emptying of the breast every 2 to 3 hours. Now, if they are on, depending on the antibiotic, they will need to throw that milk away. They need to toss that milk. Okay? If it's an antibiotic that's safe, they toss the milk from the infected breast, but they can use the milk from the other breast for the baby. If it's an antibiotic that's not safe in breastfeeding, they will have to toss the milk, period, from both breasts. But they still need to pump them. If it's safe for breastfeeding, they still recommend you tossing the milk from the infected breast because of the bacteria, but you can save the milk from the other breasts. Switching breasts is something that they have to do. They have to continue to empty both sides, because otherwise you're going to get it on the other side. And I can't imagine anything worse than having double mastitis. Okay.
After the infection clears up, are they cleared to go back to the
Yes.
breastfeeding?
Yes.
Okay.
Definitely. Warm, moist compresses help with the pain. Analgesics, they don't typically give them massive pain medicines. They just say NSAIDs, like your 800 milligram Motrin, something like that. If it is due to a yeast, and we didn't talk about that, but you can, if a baby gets thrush in their mouth, which is a yeast infection, they can get yeast on the nipple. And that's something that I always tell mothers is, if your baby's got thrush and you're still nursing, you better go ahead and get something for yourself. Pediatricians don't always think about that. They're treating the baby. They're not necessarily treating you. But you've got to get something to treat you, because all you're doing is you're gonna get it on your nipple, and then you're just constantly transferring. Isn't that awful, Nathan? Take this one. It's serious business, yeah. So you've got to treat yourself as well. Very, very important to remember that. But yeast can cause, the reason I bring this up is candidiasis can cause cracking of the nipple. And again, that leads to that bacteria crawling back in. No soap on the nipples. A lot of women want to get in the shower and soap them up so they're good and clean for that baby. And all that does is dry it out. You know how drying soap is? And so all that's going to do is it's going to dry the skin out and cause it to crack. No soap, and allowing them to air dry, and good hand washing too. Very, very important. Okay. All right. Something else that can occur is a blood clot. Blood clots. You can have two different types. You can have the superficial venous thrombosis or a DVT, a deep vein thrombosis. Okay, and that can go from anywhere from the feet all the way up to the femoral area. Typically, it's because of surgery, and with a C-section, what do you want to get? What do they need to do? They need to get up and walk. They've got to get up and walk. Any surgery, you don't stay in the bed anymore. Have y'all noticed that at the hospital with your C-sections? They may let them rest for a little bit, and boy, then they're up. There is no lying in bed. And you know, when your grandmothers were, and some of you great-grandmothers, were in the hospital having C-sections, they were there for a week. Vaginal deliveries were there for a week. C-sections were there even longer. I mean, they were there for a long time. Now you're up and moving. Okay, maybe you get to stay 48 hours, maybe. But you're up and moving. So that's one of the biggest things to preventing blood clots. Also, if they've been up in stirrups for a long time, if they've been in that horrible lithotomy position with those feet up in the stirrups, that will put them at risk for blood clotting. So getting up and moving is the best thing to do. And of course, you've got your other risk factors: smoking, hypertension, anything that can cause the vessels to be constricted, obesity, all the typical risk factors that you have as well. You know the signs of the DVT. They're the same here as they are anywhere else. And of course, you don't want to forget about pulmonary embolisms as well, because those blood clots can break off and travel up to the lungs. So the biggest thing that you can do for managing or preventing it is early ambulation. If they have a blood clot, if a ultrasound shows that they have a blood clot, they will start, and they're still in the hospital, they will start them on IV heparin first. When they're PTT, and everybody understands about PTT and PT, you know, PTT is the one for heparin. Yeah, I've shown y'all that, how they count that, right? Heparin, HEPARIN, PTT. And then Coumadin is Coumadin, PT. That's how you know which goes with what. You ever heard that?
Mm-mm.
Can we do that one more time?
Yeah.
So you've got PT and PTT.
Mm-hmm.
PT goes with Coumadin because it's COUMADIN-PT. And then heparin is PTT. HEPARIN-PTT. Look, you learned something today. So, we're given IV heparin. So, the clotting lab that we're looking for, bless you, is PTT. When the PTT regulates, normalizes, then they will start them on Coumadin. PO, and they're typically on Coumadin at home for 2 to 6 months. So what lab would they go to have checked on Coumadin? PT. Right. The PT. Y'all think you can remember that now?
Mm-hmm.
Okay. Strict bed rest if a clot is confirmed with the elevation of the leg. Elastic stockings, those horrible elastic stockings. And have y'all talked about the 3 G's that promote clotting? Or that prolong a PTT? These prolong a PTT time. That prolong the clotting.
Ginseng.
Ginkgo, garlic, and ginger.
Oh.
So they teach them to avoid ginkgo, garlic, and ginger because it prolongs the PTT time. Causes them to not clot quick enough. Prolongs the PTT. Ginkgo, garlic, and ginger.
Those elastic stockings are safe to wear even if you have a DVT already?
No,
Oh,
those
okay.
are only to prevent.
Okay, I thought.
Yeah. Okay. So treatment, again, is basically the same as you would anywhere treating a DVT. Okay. A very sad thing is postpartum depression. Okay. This is the last thing we're going to talk about with mothers, and then we'll take a break. Now, I want to tell you about postpartum depression. Postpartum depression is different than postpartum blues. It's different than the baby blues. Everybody has the baby blues. That is due to those rapid hormonal changes. Everybody gets that. I remember holding Ben and rocking in the rocking chair and crying because I didn't get the right Chinese food. They didn't deliver the right thing. I mean, stupid stuff like that, that you're just like, you just kind of lose your mind there for a couple of weeks. That is normal. Okay? Those symptoms disappear within a few days and you become a little bit more normalized. Now, your book and other resources sometimes call this postpartum major mood disorder. Okay? This begins after the first month. This is not an immediate onset. So what could be scary about that? Where are they at that point? They're home. They're out of your care. Okay? These are the women who drove their kids over the cliff or into the ocean. We had one recently. Wasn't she from South Carolina or somewhere and drove her kids into the ocean in Florida or somewhere like that? This is the mother in Texas who drowned all of her babies in the bathtub and made them all watch. Who was it? Christy Brinkley or who was that? Who was that model that had it? She was on TV for a lot. It wasn't Christy Brinkley. It was Brooke Shields. And she talks about it. These women are severely psychologically impaired. Okay? If you have a friend or anybody that says they have postpartum depression, they're on major drugs. Okay? Postpartum depression is rare. And more than likely, they did not have true postpartum depression. It was baby blues. And some people have a hard time dealing with baby blues. But this is severe. This only is within 7 to 30% of mothers. Very, very low number. Okay? All right, so some of the signs and symptoms are intense and pervasive sadness with severe mood swings, intense fears, anger, anxiety, despondency, uncontrollable sobbing. Okay? Severe, severe health. Risk factors, first-time mothers are more at risk for this. A previous history of a psychiatric disorder. And there are some other contributing things like low self-esteem, lack of support, those kind of things also. Or if they didn't want the baby to begin with, some ambivalence towards the baby or pregnancy. Now, these are the women that you do not want to leave alone with the child. They will not leave this baby. Once they are diagnosed, they take custody away. I mean, that's how severe this is, because of the fact that these are the women who will cause harm to those children. Okay? So professional mental support, psychotherapy, they put them on some pretty high-powered drugs. Lithium. This is not just your Prozac. This is the big high-powered drugs. This is other antipsychotics. Again, they may remove the child from her care or not allow her to be alone with the child. Now, who would you teach, or when would you need to teach about this? What signs and symptoms to look for? The husband or the partner or the family, and before they leave the hospital. Because a month out, number one, they're not there for their 6-month checkup yet. It's only been 4 weeks. And they're not at the hospital. What's happened at home? Probably the spouse has gone back to work, or the partner's gone back to work. The mother, if the mother of the mother was there helping, she's probably gone home by now. So a month out, who's home? The mama and the baby. And that's it. And that's when these things start setting in. That's when you start seeing these signs and symptoms occur. And that's what's so scary, because there's nobody there to stop it. That's how a lot of these women, I hate to say the word get away with, but that's when these things occur, because there's nobody there to take over, to help her. So that's what makes it so scary. So this is something that you have to teach before they leave the hospital. Stuff to look for, signs and symptoms to look for, so that they don't get caught in a situation where those horrible things occur. Okay? Again, it's rare. It is not a common thing. The baby blues are more common, but it is definitely something that we need to pay attention to. And so if you've got a mother that you're treating and you notice in her history that she has a psychiatric disorder, or even if it's just something as simple as they have depression in their history, then we need to start teaching. These are some of the things to look for. If you feel unsafe, or if you look at your baby and you just don't feel like you can handle the crying, call somebody. Have somebody on speed dial. Okay. All right. Let's take a break. About 10 minutes.
For many parents, the crying can be far more than they ever expected.
I've never been prepared for how I would feel as an individual when I had a child who cried like that.
I was getting more and more frustrated, more and more angry. Why is this happening? What am I not doing? What is Karen not doing?
But I had absolutely no idea what that crying would be like, what it would do to our lives, how it would affect every aspect of our lives for the next 5 months. I would say I grew more frustrated as the months wore on, definitely more frustrated, because I knew what was coming every single night, that there was nothing I could do about it, and I would get frustrated, just, what do you want? I have tried everything. I love you, I want to comfort you, I'm trying my hardest, but it's not good enough.
We use the term the period of purple crying to talk about this crying that occurs in the first few months of life. And we do that because the letters of the word purple each stand for one of the characteristics, which is so frustrating for parents. The first P stands for the peak pattern, where the amount of crying that occurs per day goes up and up and up until the second or third month of life and then decreases. This crying can be either a lot or a little at the time of the peak crying. The U is for the fact that most of this crying is unexpected. It starts and it stops for no apparent reason, either in the environment or in the baby, and it is very frustrating to parents for that reason. The R is for the fact that these crying episodes are resistant to soothing no matter what you do. They're not related to feeding, they're not related to dirty diapers. So even though some of these bouts are unsoothable, it's still good to try to soothe the babies. If you do, you can reduce the crying by as much as 50%. The second P is because the baby looks like it's in pain even when it's not. And the L is for the fact that the crying bouts that go on at this time are very long. Some of them can be an hour or 2 hours in length. And they can cry as much as 5 or 6 hours a day and still be completely normal. The E is for the fact that it tends to cluster in the evening or the late afternoon, just when the parents are the most tired. All of these things together are frustrating. And they're frustrating in and of themselves, and when they all occur at the same time, it can be terribly frustrating for parents, even though the baby's totally normal.
I couldn't make him stop crying. So I got frustrated. I felt like the worst mom on the planet. I felt like maybe I had a bad baby.
Knowing about the period of purple crying is very important because it allows you to plan ahead and know that this stressful, frustrating crying period is going to happen. And when you know that, you can do things for yourself and especially for other people that are going to take care of your infant to prevent that from happening.
I would just feel better about turning over Jack to somebody at that point in his life if we both understood what the period of purple crying was. If the caregiver, I could explain exactly, and they would know exactly what he's going through, that they're going to deal with the same problems that I've been dealing with, that I need to take a break from.
I would have been more comforted had I known, you know what, you may not be able to calm this baby down, and that doesn't mean there's anything wrong with you, and there's nothing wrong with your husband, and there's nothing wrong with that baby. It's just normal.
Finding out in the end that there is nothing you can do. You can't fix the problem. It took a lot of stress off of everything.
There's one very serious consequence that can come of this if parents aren't aware of it, and that is the condition we know of as shaken baby syndrome. And shaken baby syndrome happens at that instant when, in the midst of this frustration, the parents, the caregivers, whoever's taking care of the baby, just lose it. And they hear the crying, they're frustrated by it, they pick up the baby, and they shake the baby and say something like, "Don't do that. Why are you crying?" And in this instant, when the baby's head shakes back and forth, there's a very important danger and very sometimes fatal consequence of what we call shaken baby syndrome. There are a number of reasons why shaking is so dangerous. And one of these is because the baby's head is relatively big compared to its body at this age. The second is that the baby's neck muscles are not as strong as they will be later. But the most important reason is that the adult who does the shaking is so much stronger and so much more powerful than the infant.
The doctors had given her a CT scan, and it was apparent. You could see on the CT scan what brain cells were dying off, and the swelling of her brain and all that. So, you know, once you start realizing that all of these things are happening to this little baby's brain, you have to know that the outcome is not going to be good.
Now this damage unfortunately causes very serious consequences. Some of that is blindness, some of that is difficulty with motor function like walking, talking, and so on, and also later learning disabilities and difficulty with behavior, and unfortunately, in the worst case scenario, they can even cause death.
It was totally beyond my comprehension that something could have happened that caused Kelly to be in such a way as she was. She was so damaged.
I know that he loved Elijah. I know that he regrets what happened. But for one reason or the other, he lost absolutely all control that day.
Fortunately, there are some things you can do to prevent this from happening. They can also help to comfort your baby.
We have what we call 3 action steps that are helpful. And the first is that when your baby cries, you want to increase the carry, comfort, walk, and talk responses that you do. Remember that some of the times, most of the times it will help, but the baby will still continue crying sometimes, and that's okay. The second thing is, if the crying continues, and it's very, very frustrating,
that's what's important about
it's okay to walk away. Put your baby down in a quiet place, make sure it's safe, and walk away from the baby and gather yourself together again. And the third thing, very important, never ever shake or hurt your baby.
I think that parents really need to know that, some people, their baby won't cry to the levels that will absolutely frustrate them. But there are families who will have crying babies and have moments with their children that will cause them to get frustrated. And that frustration is okay. It is absolutely okay to feel frustrated. I didn't know that. That was another thing that compounded, made me feel even worse as a parent, because I didn't know it was okay to be frustrated.
It's okay to be frustrated. It's what you do when you get frustrated. And I think the biggest thing that we have to stress is set the baby down in a safe place. Make sure the baby is safe and walk away. Whether it be 5 minutes and you go back and check on the baby, whether it be 10 minutes and you go back and check on the baby. Go downstairs, do something that you enjoy doing. But you can't calm that crying child when you're already frustrated. You have to calm yourself and then try to go back and calm the child, because it's probably not going to work if you do it any other way.
It's important to let everybody who takes care of your child know about the period of purple crying and how frustrating it can be. And you may also want to be careful about who you leave your baby with. If they're going to be frustrated by the crying, then it's probably better not to leave your baby with those relatives or friends or whoever else it might be. And you want to make sure that at some point your doctor or your physician or your healthcare worker gets a chance to examine your baby to make sure there's nothing else causing the crying. And finally, take care of yourself. Do whatever it takes to give yourself a break, to have some respite, to enjoy music or whatever it is that calms you down.
And it seems like you will not make it out of this time, that these few months are going to last forever. But they really do pass, and it's not your fault. It's not anything you're doing wrong, and it's not anything your baby's doing wrong. And you will survive.
And Jack was on kind of the extreme end of it. He was a very colicky baby, but he was a healthy baby. Just like any of the programs showed, he turns out just fine.
He sure did.
Is to make sure that these mothers are taught that it's okay to walk away. It's okay. Because I think there's that guilt factor where they think, you remember how the mother in the DVD was saying, I felt like the worst mother in the world. I felt like I was doing something wrong, or I had a baby there was something wrong with my baby and I couldn't soothe him. And that's what they feel like, and so they're not going to walk away. They're not going to put the baby down and walk away, and then what's going to end up happening is what happened to the little Elijah, or the little Kelly, who was shaken by the child care provider. And I look at some of those, when Ben was in daycare, I look at some of those and think how they do it, because if you've got a room of 8 or 10 crying babies all the time, I mean, that would just... Whew, Lord, it would send you over the edge. So, but teaching them, the most important thing is put them down in a safe place. Make sure that their needs are met, that they have a dry diaper, that they've been fed, that nothing seems to be wrong. put them in a safe place, and walk away. And just walk away. Those of you who've had babies know that you have those moments, you know. And it's like the physician said, the pediatrician said in that DVD, it is so simple and quick to pick up that baby and shake because you're frustrated. And we're a lot stronger than they are. And I have seen a child, several, that have come in that are shaken. And you don't want to see it, you know, on the CT scan, because what happens is that brain bounces on the skull. Okay, so it damages the front and the back as it's bouncing back and forth. And so you don't want to see that. So very, very, very important teaching that I think it needs to be taught to every parent. I don't care if they have 20 children at home. It still needs to be taught. You've also got to throw in the factor that you've got a very tired parent, because they're having to wake up every couple hours to feed that baby. They're very tired, so they're sleep deprived. They may not have the support system that they need. If it's the mother, she's going through all those hormonal changes. And then you've got this baby who will not stop crying. And nothing you can do. So very, 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 very important to not just give them the DVD to take home, but to teach it to them. This is what's okay. And that it's okay to pick up the phone and call somebody and say, I can't do this right now. I need somebody to come watch them so I can go shopping or go somewhere. It's okay. All right, so that's what the takeaway home message I want. And how to teach them what to do, have the soothing methods, walking and soothing and talking and all that kind of fun. All that stuff is very, very important. I hope it gives you a different view. I don't want to change your view because it's still wrong, of course, to shake a baby. Definitely. But I hope it gives you a different viewpoint too on what causes it. Sometimes it's not that they're evil people, it's that they've just gotten to that point where they can't do it anymore. Okay. Anybody else have anything they want to add to that? It's a very real and very serious problem. Okay. Alright, let's move on to the baby now. Okay. And this is a picture that I've got on your PowerPoint slide. It's just kind of a conglomeration of all the different things for newborn assessment. And a lot of those things we've already talked about because you had to do a newborn assessment. Okay? But let's talk about some other things. Okay, APGAR scoring. You know, when the baby is born, they're going to do an APGAR score at 1 minute and 5 minutes. That's typically the times that they... Have y'all seen them APGAR score in the labor room? Okay, so some of the things that they're looking at heart rate. They're looking at respiratory effort. They're looking at muscle tone, reflex irritability, and skin color. Heart rate is the most important assessment at this point. Of course, if there's no beat, that's a 0. Everything, after they score it, they add it all up. Anywhere from 8 to 10 is considered good. Even at an 8, they may need some blow-by oxygen, but it's probably not enough that they have to have it to sustain life. It's just to kind of give them that little extra oomph. Anything less than 8 typically is going to need some kind of resuscitative efforts, whether it's deep suctioning or lots of oxygen, like a mask. Okay. Respiratory effort is pretty self-explanatory, I think. Apnea, a vigorous cry, which is they cry immediately, or they're slow to cry. It takes a while. It takes some stimulation to get them to cry. Muscle tone, we know that flexion is important, right? Remember, they need to be flexed. They need to have those arms flexed. Those legs need to be flexed. If you birth a limp baby, they're not flexed. They have poor muscle tone. So it goes from active flexion. Some flexion means that they may be flexed at the arms, but they're not flexed at the legs. And of course, flaccid, I think everybody understands what that means. reflex irritability is that facial expression. You can use it from that facial expression. Is there no facial expression? Are they kind of irritable? Or you know how when they cry, they scrunch up their whole little faces and they're just, they just scream. That's a grimace or a cry. And then skin color. Now, you know that acrocyanosis, remember that term, acrocyanosis? Okay, it's the blueness of the extremities, right? Acrocyanosis is considered normal in newborns up to the first couple of days. So it should be just extremities, those hands and feet. And they do get a point for blue extremities. Now, totally pink, of course, is 2. But there's a difference. Does everybody understand there's a difference in acrocyanosis and cyanosis? Cyanosis is blueness all over. I mean, their face is blue. Okay. And some babies, when they're born, they are very cyanotic until they suction them and then they automatically pink up. You see them start to pink. So that's how they score them. And they score them at 1 and 5 minutes. And we hope for what? We hope from 1 minute to 5 minutes that it goes up. We should see an improvement. We don't want it to go the other way. We want to see some improvement in the scoring. Now, when the baby is born, the heart rate again is the most important. Okay, this is the initial newborn evaluation. Let's get through that right now. Okay, newborn transition. There are 2 periods of what we call reactivity. Okay, after birth, that baby is very reactive. They're very alert. They're crying for about the first 30 minutes. They're very alert, very reactive. So that's the first period of reactivity. So their heart rate is high. That pulse is anywhere from 160 to 180. It's pretty high because they're very, very active. They're flailing around. They're screaming and crying. You're trying to get them to feed. You're drying them off. All those fun things. And then they slow down. Then everything, they go to sleep. They relax. They rest. They're transitioning to life. So their heart rate starts to go down. Anywhere from 100 to 120. Okay. There's a second period of reactivity, that occurs somewhere between 4 and 8 hours after birth. Somewhere between 4 and 8 hours of birth. Once again, they're very alert, very awake. They're ready to eat well. So they use that period of time from that 30 minutes after birth up to those 4 hours to transition. Their bodies are transitioning to this new life, this new world. The shunts have closed, hopefully. And so they've rested. That whole stressful response, that adrenaline rush of birth, they've slept, they've relaxed, they've rested, and now they're awake again. They're ready to transition. They're ready to eat. They're ready to move around. Respirations initially are very irregular, anywhere from 60 to 80. And you may hear crackles in the lungs, especially in either C-section babies. Because remember, C-section babies are not squeezed through the birth canal. That is one advantage of a vaginal birth, is that as they're squeezed through the birth canal, that fluid is expelled. And that does not occur with a C-section baby. So crackles are very commonly heard. They may have very, very small, very slight periods of apnea. Anything less than 15 seconds is considered normal. Anything over 15 seconds is not considered normal and should be investigated. Okay. They should at some point pass their meconium, that first meconium stool. If they have not passed a meconium stool within the first 24 or 48 hours, we get concerned that they may have a bowel blockage. Something's wrong. So let's talk about the respiratory system. Okay? We talked about that initial gasp. Remember when we were looking at the different shunts of the heart? That gasp is extremely important. It's triggered by pressure changes. It's triggered by chilling because their temperature is decreasing. Remember, they were a perfect 98.6 degrees in the womb, and when they are born out into that environment, they are cold, they chill. So all of those things, the pressure changes, the chilling, the light, the noise, all that stuff causes that gasp response. And that gasp response causes the little alveoli in the lungs to open. Okay, so that's a very, very important thing. What do we want to do as the healthcare provider to ensure before that gasp? That they're suctioned, that the head is born and that they're suctioned. Even in babies who did not have meconium in their fluid, they still need to be suctioned because you don't want a whole lot of fluid going into those lungs. You don't want a whole lot of fluid, but especially with meconium babies, because you don't want the meconium to be sucked down. Okay? All right. Now, when those little alveoli open, they need to be, the oxygen needs to be distributed. Okay? So the cry, that's so important, that they have to stimulate them. They dry them, they warm them for them to cry. That cry causes that inspired air from the gasp that opened the alveoli to now be distributed into the tissues. Okay, so the gas sucks in oxygen, sucks in air, causes the alveoli to pop open, and then the cry causes it to be distributed throughout the tissues. So both of those things are very important. We need for both of those things to occur for that baby to transition respiratory. Okay. That cry creates a positive pressure space. Okay. Now, in that period, that changing period where the gasp and the cry, there is a period of hypoxia. If you did, and nobody ever does it, and I guess they found this out just by chance, but if you did a blood gas immediately between those things, you would see that there was a very low level of oxygen at that point because it hasn't been distributed. But it is a very temporary period of hypoxia. And it's a very important period of hypoxia because it jolts the brain, it stimulates the brain to say, I need oxygen, I need more oxygen. And so when the baby does cry, the brain as well is jolted into helping to stimulate or distribute that oxygen throughout the body. So that's a very important period of hypoxia. And you would never know that. You'll never see that because you're not going to do a blood gas immediately after the gas. But that does occur. When do you remember when surfactant is produced? Okay. So that surfactant excretion is very, very important. Surfactant is produced and is secreted, causing those lungs to not be sticky, so that the lungs are able to do their thing. They're able to expand the way they're supposed to. When they do expand, when that baby cries, when the lungs start working, the alveoli pop open, that lung expansion helps more surfactant to be secreted. And it keeps this little alveoli that popped open stabilized so that they don't collapse again.
Do we all have surfactant now? Or is it we continuously produce it?
Yeah. So our lungs don't collapse. All right, now, What else occurs with that first breath? What else is important? What does it do? It causes the heart valves to close. This is just a kind of a diagram of what happens. The first breath, that first gasp, okay, causes a reduction in pulmonary vascular resistance. Okay. What is the first to close?
The foramen ovale.
The foramen ovale is the first to close. It usually closes immediately with that first gasp. It should close immediately with that decreased pulmonary vascular resistance. If it doesn't close immediately, it should be closed at least by 1 to 2 hours after birth. So immediately up to 1 to 2 hours. What's the other vessel that should close immediately? Venosus. Ductus venosus should close with the cutting of the cord. The cutting of the umbilical cord causes ductus venosus to close. And then the one that sometimes takes a while to close is ductus arteriosus. And it should close within 15 hours after birth. But we do have a lot of babies that continue to have a patent ductus arteriosus or a PDA. And those you can hear what when you're doing your little murmur. Have y'all heard any of those? Have you heard a little murmur, a little swishing going on in the baby's chest when you've been listening? And that's coming from those shunts that haven't quite closed all the way yet. Okay? A patent foramen ovale is very rare. I've never seen a patent ductus venosus. Those are pretty, that's something that should occur in every baby. I have seen a patent foramen ovale, and those kids do have a lot of issues, a lot of oxygenation issues. So they usually have to be surgically closed, whereas a PDA can be closed by medication, hopefully, and we'll talk about that later on. Okay? So again, that first gasp is extremely important, not only for the lungs, but for the heart as well. All right. Their heart rate, again, is going to fluctuate. It may drop when they're asleep. Have y'all had trouble counting yet?
Yes.
Extremely fast, especially when they're awake. We don't normally take blood pressures on babies, but an average blood pressure is anywhere from 60 to 80 over 40 to 50. They do the blood pressures now to check for heart issues. Have y'all seen them doing that? They'll check the blood pressure in the leg and in the opposite arm. Have y'all seen those being done? No. We do those on all babies to check for heart issues. And if you see a difference in the blood pressures, then they do a further investigation to see whether or not there's any issues, cardiac issues. But an average blood pressure is anywhere from 60 to 80 over 40 to 50. Okay. All right. Their lab values. We talked about some with the mothers. Now this is a chart of all the different lab values, but let me point out ones that are the most important, I think. There's 4 that I really think are important. The first one is hemoglobin and hematocrit. At birth, an infant's blood contains about 80% fetal hemoglobin. Fetal hemoglobin. Okay, 80% fetal hemoglobin. Why is that? Why is it still fetal? They need to carry the oxygen, but something's not matured yet. The liver has not matured yet. It can't produce its own red blood cells yet. Now it will drop after that baby is born. Okay, so it goes from 80% to 55% at 5 weeks to about 5% at 20 weeks. If you drew a hemoglobin and hematocrit on an infant, it would look like the baby is anemic. Okay, because it's fetal hemoglobin, it's not mature blood cells. It would appear to be anemic, but they're not. They're not anemic. That is a normal response. Okay, a normal response.
What did you say about they're like 5%, 20%?
They go 55% by 5 weeks and 5% at 20 weeks. So it continuously drops. We don't need those fetal, because what's happening in that time period? What's happening, hopefully, the liver's maturing, right? So we don't need all that fetal hemoglobin anymore. We need our own mature red blood cells. Okay? But in the meantime, if you drew their hemoglobin and hematocrit, they would seem to be anemic because they don't have enough mature red blood cells yet. They just have fetal hemoglobin. Does that make sense? Kind of, sort of, maybe. Okay? They're white blood cells. Okay? They appear to have leukocytosis. Their white blood cell count may be as high as 30,000. That is considered to be normal. Okay? In an infant, a sign of infection. You remember when mothers, we didn't pay attention to the white blood cell count either. Remember? We looked at for fever. In an infant, a decrease in white blood cell count is often a sign of infection because they don't handle infection well. So sepsis is often accompanied by a decrease in white blood cell count. Okay. Another lab that I want you to remember is platelet count. Why do we give vitamin K? Because they have no gut flora yet. Vitamin K is synthesized in the bowel. Remember me saying that meconium stool is sterile. Meconium stool is sterile because they don't have any bacteria in their gut yet to synthesize vitamin K. They can't synthesize clotting factors yet. So we give them the vitamin K to prevent hemorrhage. Once they are born and they start, things are start putting in their mouth, like bottles and nipples and hands and whatever else you stick in their mouth, pacifiers and all that stuff. Then they start to build up their own gut flora, and then they're able to synthesize the clotting factors. And then glucose is something else I want you to look at. A normal glucose, and again, these values are going to change. Sometimes you're going to see a 40 as normal. So anywhere from 40 to 45 up to 96 is considered normal for a newborn. If we saw a 45 on an adult, we'd be, pouring sugar in their mouth and giving them apple juice and all that fun stuff, right? But a 45 on a newborn is considered normal. And of course, who would we be most concerned about with blood sugar? Babies of mothers who were diabetic. Exactly. Babies for mothers of diabetic. Okay. Those are some things to think about. All right, thermoregulation. Where do they lose heat? From their head, right? Okay, so establishing heart rate and respirations is very, very critical. But next to that is maintaining their temperature. Okay, maintaining their temperature. What do we do first to help them prevent loss of heat? What's the first thing you do when they're born? Wipe them down. Stimulate them and wipe them down, right? We towel them down wipe them down, slap a hat on their head, wrap them up, or put them under the warmer, right? They're put under the warmer right after birth. But we get all of that liquid off of them because we want to make sure that they're able to maintain their temperature. When a baby is born, shivering is not established yet. So they can't, whereas we shiver when we're cold, and that shivering mechanism, that muscle movement warms us up, they can't do that. So if you see any kind of shivering in a newborn, it's probably seizure activity or low blood sugar. It's not that they're cold. So don't look at them and say, "Oh, honey, are you cold?" They're probably seizing. Okay, so we might have an issue there. All right. Brown fat. Did you talk about brown fat in anatomy? Y'all remember about brown fat? It's an insulation thing. Brown fat is found around the scapula, in the axilla, as well as the thoracic inlet, the spinal cord, and the kidneys. Now, why would we have more fat around the scapula, here, the thoracic cavity, the spine, and the kidneys? What is it trying to do? It's protecting the vital organs, isn't it? It's insulating the vital organs. The less mature the baby is, the less brown fat it has. So those pretermers, those little tiny things, don't have brown fat, and so they chill quicker. So that's why they have trouble regulating their temperature. Okay. Now let's talk about, I know you've seen these before. We've talked about heat loss, right? We've talked about the different ways that you lose heat. Y'all remember that? Convection, radiation, and all those fun things. All right, let's talk about it in terms of a newborn. They lose heat by convection. What is convection? How do you lose heat? Air. Okay, so it's the flow of heat from the body to the air around it, right? Okay, so you're losing body heat to the air around it. What does the temperature feel like in the nursery? It's hot, isn't it? It's high. You go into the nursery and you're like, let me shed clothes, because it's always warmer in there than it is outside the nursery. The reason for that is to prevent heat loss in those newborns by convection. So you keep the temperature stabilized in the nursery, you're going to keep the temperature stabilized in the baby. We also do what? We wrap them up. If you wrap them, if you swaddle them instead of laying them flat out for, the air to take the heat away, they're going to lose less heat. All right, radiation. How do you lose heat by radiation? It's loss of body heat to a cooler solid surface that's not in direct contact with the baby, but it's close by. Okay, so windows, for example, if it's 30 degrees outside, it's best not to put the baby's crib beside the window, because they're going to lose heat to that cooler window. So you place their cribs towards the middle of the room or on a wall away from the window, because they're going to lose heat that way. Evaporation. We've already talked about that. How do you lose it by evaporation? That's the easiest one, isn't it? Losing it by water, right? So we're drying them, making sure that they dry. And then conduction is loss of heat to a cooler solid surface that they are actually laying on. Okay, so that's why the cribs in the nursery are kept warm. Because when they lay on that crib, I mean, y'all know that. How many times have you laid on an examination table at the doctor's office and it's cold, right? You're warm and the table's cold, right? So it's the same principle. You don't want the baby to lay on something that's colder because then they're going to lose body heat. All right. This is very important. That's why I have 3 stars on it. A newborn's thermal insulation is less than that of an adult. Okay? Their thermal insulation is less than that of an adult. So they instinctively have to do other things to keep them warmer. And one of those things is flexion. General flexion, when their arms are flexed, their knees are flexed, that we've talked about a million times, it's important for a lot of reasons, but one of the things is that it keeps them warmer. When they're flexed, they lose less heat. They also have a larger body surface to weight ratio. They have a larger body surface to weight ratio. If their thermal insulation is less than that of an adult, we typically think of that as, oh, they can get really cold really quickly. But we also have to think about the fact that they can get really hot really quickly. And we can cook them way too fast. So you really have to be careful and monitor the settings that the warmers are on when you're putting a baby in there. You don't want to make it like a little oven. Cold stress is a condition that occurs when they remain too cold. And the things that you're going to see in a baby that is cold stressed, they are going to start having an increased respiratory rate. They're going to start having a decrease in blood glucose, so their blood sugar is going to drop. Because what are they using the glucose for? Energy. They're trying to stay warm. So they're using up all of their blood glucose in an effort to stay warm. So that's going to drop. Their respiratory rate is going to increase. You might start seeing some cyanosis around their mouth and their nails. Because as the respiratory rate increases, the lungs start to vasoconstrict. They're breathing so fast, they're collapsing their little lungs, so they may not have as much oxygen intake. And if you allow that to continue, they will go into a state of metabolic acidosis. If you allow that to continue, they will go into a state of metabolic acidosis. So it's extremely important to keep these babies warm, not too warm, but warm, by keeping a hat on their head and doing all those other things that we just talked about. Away from cold windows, away from cold surfaces, making sure that they're dry. Alright, let's take another little break because I'm going to write on the board. Everything has developed and matured and done all this wonderful stuff except the liver. The liver is immature at birth. Everything else is able to function. Everything else does great except for the liver. And the liver causes the most trouble. Before we get into bilirubin, let's talk about the liver. That there are enough iron stores at birth for about 4 to 6 months, okay, that have built up in utero. So there's enough iron stores from the mother in the fetal liver for about 4 to 6 months. So that's why we have to do what? What kind of formula or do we give the baby, or what kind of iron fortified formula? Or if you're breastfeeding, they recommend you continue to take your prenatal vitamins because it has a lot of iron in it. Plus they get iron from your breast milk. Okay, so we have to continue to build up iron because they can't do it yet. Remember that the liver is immature. Okay? There's a lot of carbohydrate metabolism as well. So we have to continue to give them some glucose in the form of sugar in their formula, or lactose in their formula, because, or in the breast milk, because carbohydrates are metabolized a lot differently. Now, one drawback of that fetal liver being immature is that it can't excrete bilirubin as quickly as we can. And if you remember, hopefully you remember from anatomy and physiology, bilirubin is what makes our stool brown, and it's what makes our urine yellow. Did y'all know that? Did y'all hear that from anatomy and physiology? That's what causes our stool to be brown and our urine to be yellow. The fact that our liver is able to break it down and excrete it. Alright? So, there are two types of bilirubin. There is direct and indirect. And if you ever see a lab draw, when they draw a bilirubin level, they are going to report it out as direct bilirubin and indirect bilirubin. Now this goes for your adults as well. When you have adults with liver disease or cirrhosis or any of those fun things, liver cancer, they will draw a direct and an indirect bilirubin. Okay, so let's talk about what in the normal case of things happens. Bilirubin is, what is bilirubin, first off? What is that a product of? The breakdown of the red blood cells. It's a byproduct of the breakdown of red blood cells. Because remember, red blood cells are only good for how long? 120 days. So they're going to break down, they're going to die off, and that bilirubin, that product, is released. Everybody's good so far? Okay? Good so far. So that bilirubin has to go somewhere. It has to do something. That bilirubin at that point, those broken down red blood cells, is called unconjugated or indirect bilirubin. Now, do you remember from math, do you remember conjugate, or maybe it was English? Is it English? Conjugate verbs, yeah, you know, where you add things to it. Lord, I don't remember. It's one of those courses that we took when we were younger. But do you remember it? A conjugate is what? It's something that it comes together, it attaches, right? So if you, when you're thinking about it, think about this is coming together, okay? So this free floating stuff, this yellow gooey substance, has to go somewhere, has to be used or done something with. So this form of it, this broken down byproduct of the red blood cells, is not excretable by itself. It can't go anywhere by itself. Something has to be done to it. Part of it is attached to albumin particles, albumin molecules. Okay? And then, so it's bound to albumin, and then it's transferred to the liver. The liver puts it to use. And then I've got written down here, oops, I'm too young, because in a newborn, this liver can only handle so much. Okay? And we're going to get to that in just a second. The other part of it is attached to an acid, like a fatty acid. It's attached to an acid. When it attaches to something, like the albumin or the acid, it's called conjugated because it's come together now with something else. And that changes into what we call direct bilirubin or conjugated bilirubin. That is excreted into the bile duct and then excreted in the urine and the stool. That's what makes it our pee yellow and our poop brown. Okay? So some of it's put to use by the liver, some of it's excreted. And our body on a normal basis does that on its own, and we get rid of it and we don't have to worry about it. Okay. But in comes this newborn. Okay? And what happens is that there's too much. Okay, there's too much for this young body to handle. The liver is too immature, and if they're not feeding, especially if they're not feeding well, they're not peeing and pooping like they should. So all of that bilirubin, whether it's bound or not, is building up because it doesn't have anywhere to go. Right? The liver can't handle it because there's too much of it, and it can't pee and poop out because the baby's not eating like it should. Everybody follow me so far? So here it is. It's all there. So what happens is that the body says, well, the heck with this, and it breaks it back down, and it's called deconjugated. It's free floating around, and it says, well, I don't know what to do with it, so I'm just going to break it apart, and it's called deconjugated. Now again, we're back to this gooey yellow substance that's broken apart because the body doesn't know what to do with it. There's too much of it floating around. And then it absorbs into the intestines and it permeates into the tissues. There's too much of it. See, I've got too much. And then it gets into the tissues. And that's what causes us to be yellow. Okay? So, the moral of the story is, first off, you've got to make sure that your babies are peeing and pooping like they should. Okay? They need to be eating like they should. If a mother has a delay in her milk production and the baby is not getting enough to eat, then they are not going to be outputting enough of this bilirubin that the liver can't handle. Okay? And so it starts to build up. And the tissues starts to build up in the tissues. That's called breast milk jaundice. Because they're not, and it's typically a breast problem. Now, that does not mean that bottle babies can't get jaundice. They can. But it's more common in babies who are breastfed. And it's usually due to that delay in the milk production. It may be, we hope, but it may be due to poor feeding. You know, the mother's tired, and I've had a lot of these women in. The baby is losing weight, they're yellow as a pumpkin, and it's because the mama wants to sleep, and more than she wants to feed that baby. So it could be poor feeding practices as well. But it's linked to the fact that they are not getting rid of it. Okay?
My sister-in-law had that breast milk jaundice with all 4 of her kids. And I thought it was something in the milk because what they had her to do is to stop feeding this baby for 24 hours, to pump the milk, and made her feed the baby's formula for 24 hours. Then she went right back.
It wasn't anything to do with milk. What we do is we have them pump so we can see how much they're getting.
Okay.
That's why.
She was getting like 2 meals.
Yeah.
She did that. So
Yeah.
I wanna see that next week.
Yeah, we want to see how much they're getting because they'll come in and they'll say, "Oh, well, yeah, they're eating every 2 hours. They latch on great and all that, but they're not getting anything." That's what the problem is, and so that's why we have them pump. So a lot of times, we have them in a lot. Remember that when y'all came up to the unit? Remember that little area in the back with all the little rooms that I said it's like a mini ER up on peds. We have those 3 little rooms. We get them in a lot. They're coming in outpatient to have their bili levels drawn, and then we talk to them about how much are you getting at a time, and we monitor them. If it goes too high, then they're usually admitted, and that's what we do. We have them pump the milk, see how much they're actually getting, and if they're not getting enough, then we have to supplement with formula. So, okay, so that's breast milk jaundice. Now, there is also a condition that's just physiologic jaundice. Okay, so there's 2 types. There's breast milk jaundice that's related to feeding, poor feeding practices, or the milk is delayed in getting there, and they're not able to pee and poop it out. Okay, but there's also physiologic jaundice, and physiologic jaundice is because their liver is even more immature than normal. Who would be that? Preemies. Those little tiny preemie babies will get physiologic jaundice because they're even more immature than normal. The liver's immature to begin with, and their liver is just even more immature. And they will get what we call physiologic jaundice because their body is producing bilirubin, but that liver is just nowhere near ready to do anything with it. And so it breaks it apart, the body breaks it apart because it doesn't know what to do with it anymore, and it deconjugates and it permeates those tissues, and that's called physiologic jaundice. Okay, 80% of preterm babies will get physiologic jaundice. That's a high number. That's a lot of babies with jaundice. Okay, now we monitor bilirubin levels, and different physicians consider different levels to be more concerning than others. We really don't want it to go above 15. Some physicians say 14, but 15 is, a lot of them are okay with 15. And then we have some that come in that are, that we check their bilirubin at 16. They say it's okay, send them home, but make them come back the next day. If it gets too high, we're monitoring it. It should go down. The more they feed them, the more they pee and poop, and the older they get, because as they get older, what happens? The liver's maturing, then it's able to handle that bilirubin. As they get older, those numbers should go down. If it doesn't, if they continue to go up, they can develop a condition called kernicterus. Kernicterus. Kernicterus is extremely dangerous. Kernicterus. Kernicterus is a level around 22. A bilirubin level around 22. What happens with kernicteric babies is they have brain damage. It will cause brain damage. It's a very, very dangerous situation. 22. So you start getting antsy if you've checked their bilirubin and they're like 16, and then they come in the next day and it's like 18, and then you're like, we need to stick them under the lights or do something and get those levels down. Okay. Now, so what is the treatment for jaundice? What do we do? I just said it. Billy lights. Billy lights or Billy blankets. Okay. It's like a LED light. Those blue lights. You go, have y'all seen Billy lights before? A lot of you've seen, like a black light effect. You go in the room and you come out and everything seems blue and bright and everything. It's kind of like a little tanning bed for the baby. But what it does is it breaks it down even further so it's more easily excreted in the urine and the poop. So it breaks it down even further. Another way that you can get it down is to put them in sunlight. Sunlight does the same thing. So we tell them to put their crib, not only if it's warm, because remember we've got a temperature issue too. If it's warm like it is now, they can stick their crib near a window and let the sun come in. And that sunshine, that natural light, will help to break it down as well. But of course the very best way is to increase their feedings. And so we'll have them, if they're feeding them every 3 hours, we go to 2 hours, increase their feedings. Because the more they feed, the more they're going to pee and poop, the more they're going to be able to get rid of. So if you know that they're getting enough milk, or you're supplementing, they're going to pee and poop more and they're going to be able to get rid of it. Does that make sense? So when they are under the lights, it is a big safety thing. Think about those of you who have been in a tanning bed. What do you have to cover up? Your eyes. You have to cover up your eyes. That is extremely, extremely important. They have to have the little eye patches on to keep their eyes covered, because those lights can damage the retina of the eye. So they have to have their eyes covered. You don't lotion them up or put tanning lotion on them or anything. You keep them unclothed, and a lot of people say, oh, they're going to pee and poop everywhere. Yeah, well, you pad the pad the crib well, because they are going to pee and poop everywhere. But you really need to keep them as unclothed as possible. And they lay in that. Now, and some parents have a very difficult time, especially if it's the first couple of days and those mothers are going through those baby blues. They want to hold that baby. And if they cry, they want to hold the baby. But the more they're under the lights, the better off they're going to be. If you have a parent who just cannot stand not to hold that baby, there is a thing called a Billy blanket. And essentially what it is lights in a little blanket looking thing, and you can wrap them up in it, and they can actually hold them in the Billy blanket. So there is that option as well. And depending on the level, depends on how much lights they use. They can use one bank of lights or two bank of lights. They may use the blanket with lights. So it just depends on how much they are. Where does jaundice usually start? Where do you see it first? The eyes, the top of the head, the eyes, and it works its way down. You can kind of tell how jaundice, or how high their bilirubin level is by looking to see how yellow they are, how far that goes down. If they're getting towards the bottom of the abdomen into the legs, then we're getting pretty high. So usually it should stop at the head, may go down to the chest, but if it gets any lower than that, then we're getting concerned. So the yellow of their eyes. So any questions about jaundice and bilirubin? It's kind of complicated, but just remember that there's two different types, breast milk jaundice and physiologic jaundice. Physiologic jaundice is because they're just so immature. Breast milk jaundice is poor feeding practices or poor peeing and pooping, and they just can't get rid of it yet. Okay? Does everybody kind of understand that whole principle?
There's no issue with half of it attaching to an acid. There's
No.
half that is attaching to the
Liver, the albumin. Yeah, unless they're not peeing and pooping, because that's where they get rid of it. Then that part that attached to the acid still has a problem too. Whatever's attached is going to detach because it doesn't have anywhere to go. So, all right. Has everybody got that? Everybody understand? Kind of, maybe, sort of. Okay. So what our take-home message for jaundice is to make sure that they're feeding well and that they're having enough wet diapers and enough poops to get rid of it. All right, the GI system. The GI system. Okay. We are born, do you remember in the DVD, it's the very first one that we talked about that in the womb, he said that birth is almost a redundant thing. Remember him talking about that and how we are born able to do most everything. Right? Remember that? So we are born with the ability, and he talked about this, we're born with the ability to suck and swallow. Remember that? And because he talked about the fact that we're drinking and sucking in the womb. We're drinking and sucking the fluid that's in the body and peeing and pooping it out. We're born with the ability to digest and metabolize, which is a good thing. Okay? Sucking in a newborn is coordinated with breathing. They're able to breathe and suck at the same time. You have a lot of parents, especially mothers who are breastfeeding, that feel like they're suffocating their child because if their breasts are larger especially, they're feeling like they're suffocating them. And you have to reassure them, no, you're not. They'll breathe with short little bursts. They'll suck for 3 or 4 sucks, and then they stop and take a little breath, and then they suck some more. But they're not being suffocated. But sucking is not developed until about 32 weeks. So if you've got a baby who was born before 32 weeks, they're going to have a more difficult time with sucking. And so those are the babies that we end up having to tube feed. They may have either NG tubes or orogastric tubes, the oral tubes. Okay. Some things that you may see in the mouth of a baby, there's a thing called Epstein pearls, which are little white nodules along the gum line. They look like teeth, but they're not teeth. It's just little nodules that form along the gum line, and they go away. Teeth, though, do form in utero. Teeth are present inside our gums or inside our mouth before we're born. But of course, and they continue to form as we grow and develop. Those baby teeth that come up, those little baby teeth, they're not attached to a root typically. They will fall out. There are some babies that are born with teeth. Have you ever heard of those? There are babies that are born with teeth. Those babies are not, those teeth are not attached to a nerve. And so a lot of times what the physician will do is they'll come along, they'll just pull it out. They'll just yank it out. It doesn't hurt them. They don't feel it. But it's safer because those teeth are they're not attached, so they're loose, and so they can swallow them if they're not careful when they're feeding. So they'll go ahead and pull those out. They're just little false teeth. They're false teeth. They're born with.
Will they still get 2 more?
They will. They sure will. Yeah, they're born with, what's the word I want? They're born with partials and stuff in their mouth. Okay, we talked about the fact that bacteria is not present. Y'all know that. The stomach capacity. Shoot, I need to go. I'll get it and bring it tomorrow. I've got some neat little balls. Let me go get it because it's really cool. Hang tight. I found this the other day. Or feed those babies. Because if they overfeed them, they're going to vomit it back up.
Yeah, newborns have the satiation feeling.
They do. They do have the feeling of satiation. It may not come as quickly. And then they start to cry. And then parents think, oh, they're still hungry. And they shove another bottle in their mouth. And then we got problems. Okay. Stooling. When we're talking about the GI system, we're talking about stooling. The frequency of stools, and a lot of parents are very anal about their babies' poops. And if they don't poop every day, they get very worried. Very, very worried. And they'll call the doctor and they'll say, I haven't pooped in 2 days and I need to give them a laxative. And no, because the frequency of stooling among babies is very different. What you tell the parents is as long as their stool is soft, when they do have a stool, the baby is not constipated. Okay? As long as the stool is soft, the baby is not constipated. Bless you. Who do you think would get more constipated, though? Formula-fed babies. Formula-fed babies get very constipated easily, and it just has to do with the amount of iron that we give them. Breastfed baby's stool is very grainy. And the picture that I have on the PowerPoint almost looks like worms, but it's not worms. It's like curdled milk. But it's very grainy or seedy. They call it seedy. Okay? It's kind of a yellow seedy. And I always tell breastfeeding mothers, what you take in is what's going to come out. Okay? So whatever you eat, that they eat, is what's going to come out. So if you notice more green color to their stool, you may have been eating things that were more green. So you got to be more careful with that. Gas formation in a newborn occurs just like an adult. If you're eating gassy foods, that poor baby's going to be gassy too. So things like broccoli, cabbage, all those things that people like to eat, lettuce, some salads will cause a lot of gas formation, are going to cause the baby to be gassy. So you got to be careful with that. Okay. All right. Their renal system, their kidneys, they are unable to concentrate urine at birth. And that does not occur until they are about 3 months old. So at about 3 months old, they're able to concentrate their urine. So what does the urine of a newborn look like? It's very clear. It's almost like water. It's very clear. It may be a little yellow tinged or straw colored, but it's very clear because they can't concentrate it yet. If it is cloudy, that doesn't mean they have an infection. Usually that means that there's mucus in it, and that mucus is being expelled from birth through the urine. They've just gotten a lot of mucus in birth, and it's being expelled. Okay? They may have wet diapers anywhere from 6 to 25 times in the first 24 hours. So they will go frequently. And of course, what is that related to? The more you feed them, the more they're going to pee, right? Their hydration status. So they do urinate a lot. They have a lot of wet diapers. What if a mother comes to you and says, oh, there's some blood in my baby's diaper? If it's a female, it's okay. It's due to the mother's hormones being withdrawn. Okay? All right, let's look. The next slide says assessment, because the book is kind of crazy on how it does these chapters. That stuff we really already talked about with at-birth scoring. We're assessing them frequently, and you assess them within an hour, then the first, so anywhere from 1 to 4 hours, and then every 24 hours. So you're assessing them frequently to see for changes, and that's really what I want you to take from that. Okay, let's talk about their head at birth. Okay, so flip on over to their head. And these are things that you have seen or we've talked about in newborn assessment. We talked about caput succedaneum and cephalhematoma. Has anybody seen that yet? Anybody seen a baby with those yet? No? Yes? No? Some of you? No? What are they due to? Forceps and vacuum, and if they've been pushing for a long time, if they've been laboring for a long time in the birth canal. What is the difference in a caput and a cephalhematoma? Caput does or doesn't? Does. Caput is like a cap. It does cross the suture lines. It's a spongy area. It should disappear within 3 to 4 days. It's just fluid, and it's usually caused by excessive suction or forceps use. So their entire top of their head is spongy. Versus cephalhematoma that does not cross the suture line. And what does the word hematoma lead you to believe it is? Blood. A collection of blood under the scalp that takes a little bit longer to resolve than a caput. Cephalhematoma takes anywhere from 3 to 6 weeks to resolve. The problem with a cephalhematoma is that the fact that it is a collection of blood, as it's resolving, as those red blood cells are breaking down, what could it cause in the baby? What did we just talk about? Jaundice. Because as those red blood cells are breaking down and releasing that bilirubin, then that's even more that this poor immature liver has to deal with. He already doesn't have enough strength and energy and maturity to deal with what we've got. Now, we've got all this other red blood cells. So these babies will get jaundice. Okay? The anterior fontanelle and the posterior fontanelle should be flat. Then we may see a pulsation. The anterior fontanelle is diamond shaped, and it should close within 18 months. 12 to 18 months. And the posterior fontanelle, which is triangle shaped, should close within 3 months. Okay. What about their skin? What does it look like at birth? Shiny, if they're full term. What do you see? What do they peel? They peel. That's called desquamation. There's a fancy word for that, desquamation. That's the peeling of the skin, and that usually occurs a few days after birth. They're not sunburned. Okay, and they're just peeling off those old cells, those old tissue cells. What is vernix? The cheesy looking stuff. Have y'all seen that? And it usually deposits in their folds or in their neck, anywhere like that. Vernix is a product of the sweat glands. Vernix is a product of the sweat glands. They're getting busy figuring out what to do to work, and so they're producing this vernix first off. It does go away. You can't scrub it off. You can wipe some of it off, but it will actually go away. And it usually goes away when the desquamation or the peeling occurs. That's when you start to see it go away. What are milia? Have you heard of milia? The little white spots on the face. A lot of people say, oh, they have baby acne. Those are just little white, distended sweat glands, usually on the face. You don't pop them. Do we use soap on their face?
No.
No, because that will make the skin too dry, can make those worse. There are a lot of other things that you may see on their skin. Do you know what a Mongolian spot is? It looks like they're bruised. It looks like they're bruised. It's more common in African American or Asian babies, although there are some Caucasian babies that have Mongolian spots. They do look like a purple discoloration on the skin. They have it. They're not necessarily bruised, even though may you see some bruising. Yeah, I mean you may see some bruising, especially around their head and their face from birth. But typically these are like on their buttocks or on their back, some on their legs. Okay. Nevi, N-E-V-I, nevi are little stork bites, those little red marks. Like you see, a lot of people think that they're their little birthmark, little shape. There's nothing you can do about that. They're just little, the stork didn't bite them. They may have a newborn rash. You may see like a little red rash all over their body. It's called erythema toxicum, which is a little red newborn rash. You don't need to lather them up in cortisone cream. It will go away on its own. So all those things are normal. None of those things warrant the child being rushed to the doctor. All those things are considered normal. And when you're doing your assessment on your baby, you're looking for all those different things just to see what the baby does have, what kind of marks they do have on them.
What do they call the port wine?
Port wine stains. There are some things called strawberry hemangiomas too, which are raised areas. Those are areas that there's a collection of blood vessels. They should sink down and go away. If they don't, they may need further investigation, but strawberries. Okay, so there's a lot of different things. I mean, we could go on and on and on and on. And you probably, all of you probably have some kind of mark somewhere on your body. We don't need to look at them.
I didn't know if they'd consider those in Mongolian spots or not.
No, they're usually different than Mongolian spots. All right, let's talk last about their neuromuscular system, and then tomorrow we'll pick up with what we do for them. The neuromuscular system is almost completely developed at birth, and it grows very rapidly. It's one of those things that you see developing very quickly. And remember, in the DVD at the very beginning, the nerves start to work. The nerve synapses start to work pretty quickly. So the nervous system is very developed. And remember I said that they can't shiver. So any spontaneous movement that you see, quivering, shivering, needs to be investigated. It may be something as simple as their glucose is low, and that is easily fixed. You feed them and they don't have that anymore. But if it continues, then they need to be investigated for newborn seizures. And there are things called infantile spasms, infantile seizures, that may go away later on in life. but they need to be followed by a neurologist. So any kind of shivering or quivering needs to be investigated. Now, they will have some little twitches, like in their mouth and stuff. Okay, and that's just a nervous system response. That's nothing that you need to get all up in arms about. But if they're really seriously tremoring or shivering, that definitely needs to be investigated. There's a lot of different reflexes that we've already talked about during newborn assessment. We talked about tonic neck. We talked about Moro, the grasp. That's pretty, you know about that, sucking and rooting. Babinski. Have y'all tried to elicit any of those in your babies? Those of you who have Miss Chandler, probably you've seen her do the parachute with the baby, and the baby, you know, is, yeah, the drop baby test, right, the drop baby reflex. I told her it makes me very nervous when she does that in front of students. Gallant. Have y'all seen her do the gallant, where the baby cocks their leg up on the side? Yeah. So if you've never seen her do her version of Moro or startle, then that's a whole different ball game. You want to reach out and grab the baby because you're afraid she's going to drop it. So, okay. All right, well, let's stop there. Tomorrow we'll pick up normal.